peritoneal organs. Fine. We know that they are very vascular. So they receive 20% of the cardiac output. Why are we calling them very vascular? You see their size, 150 gram in men and 130 gram in women. And they are getting 20% of the cardiac output. Compare this with liver, 1500 gram, and it just gets 15% of the cardiac output, 15% of the cardiac output, right? Now, see, we have to study this angle in relation to kidney, this angle in relation to kidney. Let me see. See, this angle is in relation to the kidney. So, this is the renal angle. This is the renal angle. Fine. So, the renal angle is formed by 12th rib and which muscle? Sacrospinalis muscle is formed by sacrospinalis muscle. All kind of renal pain, they are referred here. All kind of renal pain, they are referred here. Fine. If your patient has any kind of renal pain, they all will be referred here. And you know, there is something called as hepato renal pouch. What is the significance of hepatorenal pouch? This is the most dependent part in a supine patient. Remember, you studied fast, focused assessment with sonography in trauma. Remember the 4 areas, PPPP, perihepatic, perisplenic, pericardial, and pelvis. Why do we do the checking in perihepatic area? Because we want to check the hepatorenal pouch. Fine, because that is the most dependent part in a supine patient. That is the most dependent part in a supine patient. Most dependent part in a supine patient. Fine. See. Not important. This is important. Fine. So you can see kidney has a renal capsule. This can be easily removed. This is not very strong. Fine. But what is strong is this. What is strong is this. Gyrota fascia. Gyrota fascia. Gyrota fascia. Fine. Now, gyrota fascia is extremely strong. So strong that even if cancer comes, cancer will take very long to breach gyrota fascia. Therefore, the renal cancers, instead of going out, they go inward. They prefer to spread by the renal vein and inferior vena cava. They prefer to spread by renal vein and the inferior vena cava because they know that if they try to go out, gyrota fascia will not allow them to go out. It's very strong fascia. Fine. So kidneys, they have a capsule which can be easily stripped off, fine, and they have very strong fascia called gyrota fascia. Gyrota fascia, from your knowledge of anatomy, you know, has 2 parts. Anterior part is known as fascia of Talt. Posterior part, as you know, is known as fascia of Zuckerkant, is known as fascia of Zuckerkant. Fascia of Zuckerkant. Fascia of Zuckerkant. Now you see, if you get to see at this part, if you get to see at this part, what is this? This is the renal pelvis. What is the capacity of renal pelvis? It is just 10 ml. Capacity of renal pelvis is just 10 ml, just 10 ml. So anterior to posterior, what is there in this region? Vein, artery and pelvis. Vein, artery and pelvis. Fine. Vein, artery and pelvis. So applied anatomy, renal vein is longer on the left side. Renal vein is longer on the left side. Hence, left kidney is preferred for transplant. Hence, left kidney is preferred for transplant. Is preferred for transplant. Fine. Is preferred for transplant. We speak about renal artery. We speak about renal artery. Fine. So renal artery, it arises from aorta, where at the level of intervertebral disc between L1 and L2. At the level of intervertebral disc between L1 and L2. And you know, this is all just a revision for you, that 95% of the abdominal aortic aneurysms, they arise below the level of origin of renal artery, below the level of origin of renal artery. Fine. Note down this, and then we move to something more important. Move to something which is much more important in the anatomy. Something which is much more important in the anatomy. Right. See, this is much more important. What is this? You see the renal artery. You can see here that the renal artery is getting divided into two arteries. Getting divided into two arteries. Fine. 1 and 2. These are the branches. Now, if you see this area is comparatively avascular. This area is comparatively avascular. So what is this area? This area is called Brodal plane. This area is called Brodal plane. Fine. Brodal plane. For example, there is a stone over here. If you want to remove this stone, you cannot go from here because you will damage this artery. You cannot go from here because you will damage this artery. So this is the only safe path from where you can reach the stone, from where you can reach the stone. Brodal plane. I'll show you another image. See here. So if you can see, this is the Brodal plane. This is the Brodal plane. So this is seen on the posterolateral part. This is seen on the posterolateral part. Fine. So Brodal plane is a vascular plane And avascular plane is very important when you are, dealing with the organ which is as vascular as kidney. Avascular plane on the posterolateral part of kidney, posterolateral part of kidney, fine, posterolateral part of kidney. Now, only two or three lines about the ureters, two or three lines about the ureters. So they also arise at the intervertebral disc between L1 and L2, L1 and L2. So usually they are 25 to 30 centimeters long, 25 to 30 centimeters long, fine. And you have already read this, that there are actually 5 sides of ureter getting narrowed up. That means the stones will lodge at this point. First is pelvi-ureteric junction. Pelvi-ureteric junction. Fine. Second is crossing of the ureter with iliac vessels. Iliac vessels. Fine. Crossing of the ureter with broad ligament in females, fine, and vas deferens in the males, vas deferens in the males. So about my handwriting, tomorrow the handwriting will definitely improve, Nothing gross will happen between today and tomorrow, but tomorrow I'll do the better setup. I'll be using my iPad. Today I'm writing on a slate, fine. So that is why the shaky handwriting. Tomorrow I'll use the iPad. And the other thing, because I have been writing all night long, so my hand is kind of tired. I know that's an utter excuse actually, but tomorrow definitely I'll be able to write better. Fine. Fourth is where the ureters they penetrate the outer layer of bladder. And fifth is the intramural part. Intramural, that means inside the wall of the bladder, So these are the 5 sides of ureteric narrowing, 5 sides of the ureteric narrowing. Fine. 5 sides of the ureteric narrowing. Kindly allow me to move forward. We'll start discussing the congenital anomalies. Fine. Congenital anomalies. Again, the fact-based, the one-liners. Congenital anomalies. So the most common congenital anomaly is a functional one, vesico-ureteric reflux. Vesico-ureteric reflux. It is U. Vesico-ureteric reflux. Vesico-ureteric reflux. Most common congenital anomaly of the upper urinary tract is the duplication of ureter. So supernumerary means more than one. Supernumerary renal artery is the most common congenital vascular anomaly, and it must always be kept in mind that accessory Accessory means extra. Accessory renal artery is more common on the left side, whereas accessory renal vein is more common on the right side, is more common on the right side. Fine. Now we start with the first one. First one. What is that? Dromedary hump. Dromedary hump. Let me show you there. Dromedary hump. See. So fetal kidney is like this. Lobulated. Before a child is born, these lobulations, they are all smoothened up. They are all smoothened up. But one of the lobulation may remain. One of the lobulation may remain. This will be called as dromedary hump. Dromedary hump. Now, this is a perfectly normal finding. We don't need to worry about it at all. See, dromedary hump. Before birth, it is like what is shown in the image A. So image B is dromedary hump. Do you guys notice anything unusual in the image C? So image C is showing hypertrophied column of Burton. See, this much cortex is extra. This much cortex is extra. It seems like the cortex has gone into the medulla. The cortex has gone into the medulla. So this is what you need to identify in the image-based question you see here. Can you notice this? Prominent column of Burton. Prominent column of Burton. So I'll write it down for you guys so that it is easy for you to understand. Dromedary hump. Dromedary hump. So what happens is in the fetus, the kidney is lobulated. The kidney is lobulated. At birth, the lobulations disappear. If one of the lobulation remains, especially on the convex surface, especially on the convex surface, it is called dromedary hump. Dromedary hump. Fine. It is considered a normal finding. It is considered a normal finding. So what is hypertrophied column of Burton? Hypertrophied column of Burton. So this is just invagination of cortex into medulla. Invagination of cortex into medulla. Fine. Invagination of cortex into medulla. Hypertrophied column of Burton. Hypertrophied column of Burton. Now we move to the next main disorder, that is horseshoe kidney. Horseshoe kidney. Fine. Let me slide it up a bit. Okay. Not important there. Fine. Now you can see the lobulation. Black pen. See? Can you see the lobulation? Fine. This is normal. This is normal. So this is hypertrophied column of Burton. See. So what are they? Persistent fetal lobulation. Persistent fetal lobulation. Normal. This we'll study later. Now, horseshoe kidney. Horseshoe kidney. You know, like all the other important organ of the body, kidneys are also not formed, at their natural position. So they are formed in the groin and ultimately they ascend up. What may stop their ascent sometimes is the inferior mesenteric artery. Inferior mesenteric artery. So they will stop, the inferior mesenteric artery will stop the ascent of kidneys. Ascent of kidneys. They will stop the ascent of kidneys. That is why the kidney usually is low lying and it is more prone to trauma. It is more prone to trauma. Fine. Horseshoe kidney. Horseshoe kidney. Fine. So what is horseshoe kidney? So it is failure of ascent of the kidney. Ascent of the kidney during normal development. During normal development. This occurs due to fusion of the kidneys at one of the poles, due to fusion of kidney at one of the poles. And most commonly, it is the lower pole. Most commonly, it is the lower poles. Now, like this. Sorry, let me draw a better diagram. Very bad hand at drawing. Fine, like this. Now, which artery? It is the inferior mesenteric artery which will halt the ascent. Inferior mesenteric artery which will halt the ascent. So the inferior mesenteric artery halts the ascent. Inferior mesenteric artery halts the ascent. Fine. So the isthmus lies in front of L3 and L4 vertebra. Fine. Now that means the kidneys are low lying and they are prone to injury. They are prone to injury. They are prone to injury, right? Prone to injury. Now it is slightly more common in males, slightly more common in males, slightly more common in males. Clinical feature, majority of the patients are asymptomatic. Fine. Majority of the patient, they remain asymptomatic throughout their life. They remain asymptomatic throughout their life. Urinary tract infection is the most common presentation, and in UTI, urinary tract infection, vague abdominal pain is the most common presenting feature. It is the most common presenting feature, most common presenting feature. Fine. Now, what do you get to see? on examination, because it lies in the abdomen now. Fine. What do you get to see? On examination, a firm mass. Fine. A firm mass which is non-mobile and present in the midline. Fine. Now, surprisingly, this mass will be resonant on percussion. Why? Because the intestine lies in front of this. Intestine will lie in front of this. Intestine will lie in front of this. What else you get to see? See, let's say this is the abdomen, and here is your horseshoe kidney. Now this is solid. So you expected a dull note. But you know that the intestine is covering this up. Because intestine is covering this up, so there will be resonant note full of percussion. Now, Rovsing sign. Have a look at this. Now, just imagine your patient standing straight and bending backwards. What will happen? When your patient bends backwards, the kidney will put strain on the inferior mesenteric artery. Imagine your patient is standing straight and bending backwards. Inferior mesenteric artery will be lifted up. It will be strained. So blood supply to the intestine will be stunted for a while. Because inferior mesenteric artery will be compressed. Fine. So what happens in the Rovsing sign? There is pain abdomen and nausea on hyperextension of the spine. Hyperextension on the spine. Now this can cause hypertension. This can also cause hypertension, repeated infection and calculi. These patients, they are more prone to development of malignancies. Fine. Investigations. Intravenous urography. Let me show you one image. See, what do we do in the intravenous urography? We inject a dye in the blood. Fine. The dye reaches the urinary system, and then we take the X-ray. This is the image which we get to see. Intravenous urography. When we perform this kind of investigation in our patient, fine, we'll get to see something like this. Otherwise, we would have seen something like this. Fine. Now we get to see something like this. Fine. So this is called flower vase appearance. Fine. And then we also call it hand joining sign. We also call it hand joining sign. So intravenous pyelography shows hand joining sign due to medialization of the calyces. Fine, hand joining sign. It is called flower vase appearance due to bent ureters, also called as high insertion of the ureters, also called as high insertion of the ureters. So surgical treatment is pyeloplasty. Fine. Isthmus is cut only to have access to aorta. If we want to do any surgery on aorta, only then we will cut isthmus. Only then we will cut isthmus. Fine. Only then we'll cut isthmus. Fine. Now we move to the next disorder, that is polycystic kidney disease. Polycystic kidney disease. Fine. The problem is it is an autosomal dominant disorder with a defect in chromosome number 4 and 16. Chromosome number 4 and 16. Chromosome number 4 and 16. Fine. Chromosome number 4 and 16. Fine. So multiple fluid filled swellings, they develop in the kidney parenchyma, and they develop in both the kidneys. They develop in both the kidneys. So most common age of the development is 30 to 40 years. 30 to 40 years. Most common clinical feature is hypertension. You'll see what causes hypertension. See, let's say, just a minute. Let's say that this is the renal artery. Fine. I'll draw it over here so that you can understand. Let's say this is the renal artery. So the renal artery will go like this. The branches of the renal artery will go like this, because around the surface of the cyst, they will get twisted up. Around the surface of the cyst, they will get twisted up. Fine. That means to the periphery of the kidney, less amount of blood will be reaching. To the periphery of kidney, less amount of blood will be reaching. Let me draw this somewhere else. Okay, I'll draw this here. Which color shall I choose? Bright red. So you see, blood vessel of the kidney will move like this. So you see, less amount of blood will be reaching this area. When less amount of blood reaches kidney, kidney activates the renin angiotensin system. Kidney activates the renin angiotensin system. With the help of renin angiotensin system, what happens is hypertension may occur, because the vasculature of the kidney, the blood vessel of the kidney, they are distorted. Fine. Most common clinical feature is hypertension because of activation of renin angiotensin system, because of activation of renin angiotensin system, there occurs polyuria. Why? Because kidney loses the filtration ability. Kidney is not able to filter the urine properly. Kidney is not able to filter the urine properly. There occurs hematuria. There occurs hematuria due to rupture of cyst. Due to rupture of cyst. Fine, rupture of cyst. Fine, rupture of cyst. Another clinical feature is palpable lump in abdomen. Palpable lump in abdomen. See, the kidney can be as big. See, such a huge kidney, such a huge kidney. Fine. It may be up to 20 liters in volume, up to 20 liters in volume. Fine. Lump in abdomen, which is firm and ballotable. Ballotable means you can move it between your two hands. You can move it between your two hands. Move it between your two hands. Fine. Apart from this, cysts are found in other organs also. So most commonly, they are found in liver. They are found in liver. Fine, liver. So cyst can be seen in the ovary. Cyst can be seen in the pancreas, even in the seminal vesicle, even in the seminal vesicle. Fine, but cysts, they are not seen in lungs. Cysts, they are not seen in lungs. Fine. Now, it is also associated with perianeurysm. It is also associated with perianeurysm and colonic diverticulosis. Colonic diverticulosis. If we want to do the investigation of choice is contrast CT. Investigation of choice is contrast CT. Intravenous urography shows spider leg appearance. Spider leg appearance. See here. So the same thing which happens to the blood vessel, that same thing will happen to the collecting system, that will be compressed. That collecting system will be thinned out. Fine. So there will be spider leg sign. Fine. Spider leg sign. Right. Spider leg sign. Now, you know this Swiss cheese sign, multiple bubble appearance. So they are the names for the gross appearance of kidney. How does the kidney look like? Fine. Now the treatment. First and the foremost, actually the most important, is control over hypertension. You can use angiotensin antagonist, control over the hypertension. Why? Because the most common cause of death, because the most common cause of death is cardiopulmonary complications. Fine. If hypertension is controlled, then the most common cause of death is chronic renal failure. Why? Because we know that the disease is progressive. Disease is progressive. Disease is progressive. Fine. Disease is progressive. So what is the treatment then? The treatment is excision and renal transplant. Excision and renal transplant. Rovsing operation is palliative operation. Palliative operation. That means it will just treat the pain. What do we do? Let's say there are multiple cysts. Let's say there are multiple cysts. Will puncture and remove the wall of each cyst so that the kidney smoothens up. Smoothens up. Fine. Roasting operation is palliative operation just for relief of pain. That is, we do de-roofing of the cyst. We do de-roofing of the cyst. Fine. So that will just give us relief from the pain. Relief from the pain. This will study with the topic of urology. Fine. Because they are all the ureteric disorders. Fine. So after this, we have to study the topic of ureter. But let's first finish with the topic of kidney. Let's first finish the topic of kidney. This we'll study when we start the topic of ureter. Fine. Now, we'll start with the topic of stones. We start with the topic of stones. Fine. The renal stones. The renal stones. Fine. Now, you see here. What is this? This is the surface. This is the surface of calcium oxalate stone. This is the surface of calcium oxalate stone, which is seen by microscope, electron microscope. Such a sharp colored, such a sharp structure. That is why, the stone, it causes so severe pain. So severe pain. So severe pain. Fine. Now, the renal calculi, the nephrolithiasis. Fine. So the most common stones are calcium oxalate stones. Calcium oxalate stones. Fine. What are the theories of? Can anyone tell me which stones are more common? Calcium oxalate dihydrate or calcium oxalate monohydrate? Which stones are more common? So what are the theories of stone formation? I understand because by now you guys are tired and you don't feel like answering. Fine. Yes, someone answered. No, Dr. Pankaj, it is a dihydrate which are more common. I'll just tell you how. Fine. So there are two theories, that is Randall plaque theory. Randall plaque theory. Fine. Now what happens is, let's say this is the stream of urine. This is the stream of urine. Fine. Now suppose this urine has got some salts. Fine. What will happen? More of the salts will be deposited on this. More of the salts will be deposited on this. Fine. So Randall plaque is deposition of salts in the urine acts as nidus. Nidus matlab base. Nidus for stone formation. Nidus for stone formation. Fine. Randall plaque theory. What is the next theory? Next theory is Carr postulate. Carr postulate. Carr postulate. Suppose this is the inner surface, fine, of the kidney. So they say when the lymphatics they are blocked, when the lymphatics they are blocked, fine. So they swell up. They swell up. And over these swollen lymphatics, salts may be deposited. Salts may be deposited. Carr postulate says that the stones they form due to blockage of lymphatics, due to blockage of lymphatics. Fine. Now, what are the risk factors? Hot